اتفضلوا.
Bismillah ar-Rahman ar-Rahim. Welcome in this new CME meeting of Egyptian Society of Nephrology and Transplantation, online meetings. Today we will speak about critical care nephrology in the form of plasma exchange. And I am pleasured to share the moderation of this session with my dear friend and colleague, Professor Yasser Nassar. He is a professor of critical care nephrology, Cairo University, in Sharif Mukhtar unit, which is well known, Professor Sharif Mukhtar unit, and the critical care nephrology department in Asr Al Aini. Yasser received his postdoctorate training in interventional cardiology in France, and became one of the main players in this field, especially in critical care nephrology, as being one of the instructors or the representative of European Society of Intensive Care Medicine in regarding critical care medicine in Egypt. And we shared a course in critical care nephrology with him about 5 years ago, as I remember, or 4 to 5 years ago, and shared the instruction of this course. Also, Yasser did a very good job and well-known job in combating COVID. In COVID battle in Asr Al Aini, he was responsible of the ICU in Asr Al Aini Teaching Hospital ICU, and in the first wave of COVID, which resulted in a very good results and outcome regarding this ICU in the first wave, difficult wave in the pandemic. Yasser was the leader of this ICU at this time. Our speaker today is Professor Ahmed Fayed, Assistant Professor of Nephrology and Internal Medicine ICU in Cairo University. Ahmed is my dear brother, my dear colleague. He shared me the journey of critical care nephrology since it started in Asr Al Aini in 2014. Ahmed has many publications internationally in the field of plasmapheresis and plasma exchange, and in the field of cryoglobulinemia. And last one, as I remember, was published about cryoglobulinemia in International Urology Journal about 1 month ago. Ahmed also is has accepted abstract about this plasma exchange in the coming conference of European Society of Nephrology in Milan, and he is well known and by his activity in internal medicine ICU and together in acute kidney injury group of Asr Al Aini. Today we will speak about plasma exchange, and we have many talks about plasma exchange, but we are trying this session to highlight this from another way, another view about what is the experience of Asr Al Aini in treating this plasma exchange in internal medicine ICU. Cases, number of cases, distribution of diagnosis, difficulties, complications, outcome regarding the use of this modality in treatment, of course, in addition to immunosuppressive treatment. And we'll discuss, if we have enough time, some challenging cases regarding this modality. So let me start our journey. Before this, I would like to thank Dr. Mu'tasim Fayed for being our coordinator today from Mansoura Kidney and Urology Center, and for his work regarding this session and after session on our social media forum, and all over his help to me in continuous medical activity of Egyptian Society of Nephrology. Welcome all our professors attending and all our attendees, and we hope to have an interesting session followed by an interesting and heavily scientific discussion. Yasser, please. unmute yourself if you want to start the session.
Yes, welcome everybody. I'm honored to be part of this scientific session. I'm very hopeful to listen to Dr. Ahmed Fayed and discuss his experience in plasma exchange in the critical care settings. I hope you all enjoy it, hopefully, inshallah, and we'll meet after the lecture, inshallah. Thank you, Dr. Yasser, very much for having me today, and Dr. Ahmed Fayed and Dr. Hisham, and everybody, thank you very much for having me.
Okay. Ahmed, Dr. Ahmed, please start, Professor Ahmed.
Okay, thanks, Dr. Yasser. Thanks, Dr. Yasser Nassar and Professor Hisham Sayed. Thanks, Dr. Yasser, again for this. Hope to prescribe what we will do in the critical care medicine in Qasr Al-Ain. And today we will short agenda that introduce a short introduction about the plasma exchange, and then we will talk about the special consideration in the critically ill patient and what is the clinical indication of the plasma exchange in the critically ill patient. And at the last, we will told you what is the ICU internal medicine 1 year experience in this. All of us know this apheresis. It is a Greek name which means taking away. It is the procedure where the therapeutic removal of the macromolecule from the plasma is done for therapeutic reasons. So that it is indicated in the condition where the substance that are not removable with conventional dialysis must to be removed from the blood. And this diagram represents what is apheresis in the clinical practice. We can separate the RBCs in the sickle cell disease and in the malaria, and we can do the YBCs separation for the leukopharesis as in leukemia and in the cell therapy or in the photopharesis, and for the platelets in the thrombocytosis, and what we will talk today in the plasma exchange or the plasma apheresis that is done in the cases of the thrombotic thrombocytopenic purpura, Guillain-Barré syndrome, myasthenia gravis, Kupffer, and the Waldstrom disease. There is very important to know that there is the two general mechanisms that is explained, which is the removal of the pathological substance from the body, in addition to the replacement of the missing or the abnormal plasma component. This is the two general mechanisms. That is how the plasma exchange acts. So that the plasma exchange reduces the plasma viscosity, with consequence that the improvement of the blood flow in the microvasculature. And the pathological substances that can be removed by the plasma exchange are the autoantibodies, immunocomplexes, complement products, and the cryoglobulin, and in addition to the protein-bound toxin, and also the lipoprotein, which is known as the lipopheresis. Again, to the mechanism of action, all of us after removal, there will be a rebound increase in the antibody production that will occur unless there is a concomitant immunosuppression is used to prevent the resynthesis. So the very important thing, the plasmapheresis is most utilized with other immunosuppressive strategy to decrease the production and to reduce the inflammation. So we can't use it alone. We must to be used with other immunosuppressive strategies. And the two major modalities, all of us is known to separate the plasma from the blood during the plasmapheresis, either by centrifugal-based plasma separation or the plasma membrane-based plasma separation. This is the two available methods or the modalities. And this is the centrifugal-based plasma separation, where we use the centrifugal force to separate the whole blood into plasma and the cellular fraction according to their density. And this needs the anticoagulation with high dose, and mainly we use in this the citrate anticoagulation. While this, these modalities that will we discuss, this is our experiences will talk to you, is the membrane-based plasma separation. In this diagram, this will show us this is the filter of the plasma exchange with the pore size 0.3 to 0.5 micrometer, And here, the blood will flow along the length of the interior surface of the fiber, where the plasma components such as the immunoglobulin, albumin, and the immunocomplex, which pass through the pores of this fiber and collect outside the fiber. And also, the wall of this membrane or the filter function as a separating membrane with the size that allows the penetration of the plasma, but not allowing the penetrations of YPCs, RBCs, and the other platelets component outside the plate, outside this membrane. And this diagram represents this membrane-based plasma exchange, and previously known as the immunoglobulin M antibodies are cleared more effectively with the centrifugal plasma exchange method than the other classes of this, because they are retained in the vascular compartment almost wholly. But the recent study and recent randomized controlled prospective crossover study comparing between the centrifugal method and the membrane post-treatment have the comparable removable efficacy of both IgG and the IgM. So the centrifugal, it is not superior in removal of IgM than the membrane therapeutic plasma exchange. And there is the other modalities of the, which is the new plasma exchange that is considered, is called the immunoabsorption. Simply, there is an additive absorptive column that added to the circuits of the plasma exchange, either centrifugal or the membrane, to remove the specific plasma component. And this is known as immunoadsorption, which is important for minimizing the need for the replacement solution. And this technique of immunoabsorption is known as double filtration, because we add another column in addition to the circuit that we used. It is called the double filtration plasmapheresis. And that is the system where the membrane-based plasma separation followed by secondary plasma fractionator that is remove the specific substance according to the molecular size and weight. And due to the antibody kinetics, the importance of this new immunoadsorption is to remove 2.5 to 3 times the estimated plasma volume that is usually proceeded during the simple plasma exchange treatment. And we use this now immunoadsorption especially to remove the anti-APO and the anti-HLA antibody in highly sensitized transplant recipient. And this is represented, this is the plasma separator, and this is the plasma immunoadsorption. And this is also the real life picture for the immunoadsorption method. Now to go to the special consideration in the critically ill patient. First of all, the critically ill patient is more likely to experience the following. First, to be hemodynamical instability and the coagulation disorder, and also the electrolyte abnormality. And the adverse events of the therapeutic plasma exchange are more frequently to be occur in the critically ill patient in the first procedure, especially in the first session. This mostly occur in the patient with certain diagnosis, like the patient with autonomic instability, and also with the patient with the low starting hematocrit, because this leads to the low hypotension, and also when we use the plasma replacement in the critically ill patient. So we only restrict the plasma replacement in the critically ill patient to certain patient, and we avoid to use it unless it is required to correct a complement or coagulation factor deficiency or needed to prevent the bleeding complication. And also the very important thing in the critically ill patient, the therapeutic plasma exchange remove the pharmacological agents which reduce it to critical medication to the sub-therapeutic level, especially with the antibiotic. But on the other hand, this may be considered a favorable, especially in the drug overdose. This is the special tips and tricks that is occurs in the critically ill patient. And there is the two main important questions that will be asked when we use in the critically ill patient the therapeutic plasma exchange and the intermittent hemodialysis. Which to be started? The answer of this question, the general, it is recommended to perform the therapeutic plasma exchange first, because the intermittent hemodialysis will used to correct the electrolyte and the acid-base balance, and especially the excessive volume-related issue that occurs as the result of the therapeutic plasma exchange. And the other issue, when we ask it to use the therapeutic plasma exchange in addition to the CRRT, which is the continuous renal replacement therapy, which either we can discontinue the CRRT therapy for the duration of the therapeutic plasma exchange, or it may be used the two procedures simultaneously, and they may be run either what is meant by the barrel circuits or in series circuits. This diagram will show that the in barrel and the in series circuits. In the first one here, the in barrel circuits, here is the blood go, and then it is bifurcates here into the plasma exchange, and the other one into the CRRT. But these methods need to be split, need high blood flow, and they need the higher anticoagulation, so it is may not be suitable in the critically ill patient that is liable to be hypotensive and liable to be have the bleeding disorder. Circuits which will run here. This is the blood from the patient passed to the plasma exchange, and then there is the replacement fluid, and then the returning blood enters here into the patients with the CRRT, and this containing the low needs the low anticoagulation level, and also we can start with the low total blood flow. When we go to the other issue, which is very important, especially in the era of the COVID, when we go to do the patient plasma exchange and the ECMO, which is the extracorporeal membrane oxygenation, simply the plasma exchange can be successfully performed while connected to the ECMO circuits. And the other issue which is important for the nephrologist, especially when giving the rituximab, the very important thing when to give the plasma exchange before or after the rituximab, it is recommended to perform therapeutic plasma exchange 24 hours after administration for the rituximab. And this diagram represents simply what we will do. There is here first, which is the mechanism of the plasma exchange for the removal of the pathological substance and the delivery of the efficiency plasma. And here how we prescribe according to the plasma volume and the vascular axis and the number of the session and the interval between the session and the anticoagulation and type of replacement fluid and the drug dosing, especially in the patients with critically ill patient. And this is represent the diagnostic workup for the biochemistry, for the complete blood count and the coagulation, and what we monitor here. And this diagram summarizes what we will do in the plasma exchange in general, not in the critically ill patient. And this is the technical issue related to the plasma exchange. All of us know that how we estimate the plasma volume by calculating the 0.065 body weight in kilogram multiplied by 1 minus the hematocrit. And the blood flow usually, as I said, in the membrane plasma exchange between 130 to 150 milliliter. And we use the 2 liters of the saline in 0.9 milliliter, where we used in the priming of the therapeutic plasma exchange circuits. And as the heparin, we give 5,000 units at the starting dose, and then 1,000 units given hourly later on. About the choice of the replacement fluid, our experience according to the publications that we published, approximately 65% of the replacement fluid was colloid. We separate the fluid into 65% and 35%. 65% is the colloid, which is either in the form of the 5% human albumin or the fresh frozen plasma. And also the remaining 35, we mainly use the isotonic solution in the form of 0.9% saline. But in the case of the thrombotic thrombocytopenic purpura, we use the fresh frozen plasma, and we go this separately into each diagnosis, which replacement fluids that will be given. And this is the investigation that we talk in before every session of the plasma exchange. The important thing is the platelet count, which should be cautioned, especially if less than 40,000, because unless the disease is associated, we use the fresh frozen plasma as must if it is less than 40. And the plasma fibrinogen also, if less than 150 milligram, fresh frozen plasma is must to be used as a part of the exchange fluid. And also the prothrombin time, if it is prolonged more than 2 to 3 seconds, we must to use the fresh frozen plasma as an exchange fluid. And the use of the serum calcium, if less than 8.4 milligram, we must to increase the provider, the replacement fluid to the albumin and the fresh frozen plasma. And the potassium, this is very variable and depending on the change in the renal function, in addition to the plasma exchange, to adjust the potassium replacement according to the serum potassium. When to go to the clinical indication for the critically ill, all of us know that the ASFA, which is the American Society of the Apharesis in the 2019, and also the Japanese Society for Apharesis in the 2029, which review the all indication and the plasma exchange and summarized the available trials. And they categorized into 3 categories. Category 1, where the plasma exchange is used as the first line therapy. First line, either a primary standalone or in conjugation with the other treatment. And the category 2, which is considered as the plasma exchange as the second line, which is used as standalone or in conjugation with other modality. And the category 3, this is individualized, the case by case, depending on, because the optimal rule of apharesis in this category 3 is not established, but used in case by case. Category 4, where that the plasma apharesis is ineffective or harmful, so it is not to be used. This is the ASFA and also the Japanese guideline category for the plasma exchange. In the ICU, the indication of the therapeutic plasma exchange is divided into the absolute, which shows that it is a well-established, evidence-based, recognized as the first line therapy, which is the plasma exchange. And the second, which is the relative in which the therapeutic plasma exchange is the second line, either alone or in conjugation with other treatment. And the third, it used as the rescue therapy. It can be used, but with the limited evidence, and the benefit is done by case. So that the category 1, the first important of it, which is the antiglomerular basement membrane, and also the ANCA-associated vasculitis, which is all variant, which including the microscopic cholangitis, the granulomatosis with cholangitis, and renal limited vasculitis, and also the eosinophilic granulomatous cholangitis, and the catastrophic antiphospholipid antibody syndrome, hyperviscosity syndrome, and the thrombotic thrombocytopenic purpura, and the acute inflammatory demyelinating polyradiculoneuropathy or the Guillain-Barré syndrome, myasthenia gravis, and acute liver failure. And when we'll discuss every category of this, the acute liver failure, we will not use in category 1 the conventional plasma exchange, but we use the high volume plasma exchange, which use the replacement for the plasma volume 8 to 12 plasma volume. In the conventional plasma exchange, we use 1 to 1.5 volume of the plasma exchange also. But in the acute liver failure that is bought recently in the category 1, we need the high volume plasma exchange. And when to go to the category 2, includes the cryoglobulinic vasculitis, acute disseminated encephalomyelitis, autoimmune hepatitis, and also the thyroid storm. And the category C in the ICU, which is individualized base by base, and according to maybe they used as the rescue therapy, thrombotic microangiopathy, but it is an infectious associated. HELP syndrome, and the heparin-induced thrombocytopenia, and the hypertriglyceridemic pancreatitis, and the great dilemma with sepsis with multi-organ failure. First, every category I will discuss the rationale and what is the indication. First is the antiglomerular basement membrane. The rationale is the removing of the anti-GBM that bind to the type 4 collagen in the glomerular basement membrane and in also the alveolar basement membrane. The indication, it's the diffuse alveolar hemorrhage. This is the clear indication. Also is the dialysis independence. And in the dialysis dependence with no diffuse alveolar hemorrhage, it is reduced to the category 2, not category 1. This is the category, and the second one is the evidence-based. And the frequency, we do it daily or every other day for 14 days or until the anti-GBM is undetectable. And here the replacement solution is albumin, but the plasma if diffused alveolar hemorrhage or recent renal biopsy is done. I want to go to the other one, which is the category 1, hyperviscosity syndrome. The rationale is to reduce the viscosity by removing the IgM, and as we say, membrane is equal to the centrifugal molecule in the Waldenstrom macroglobulinemia, or also the removal of monoclonal IgA or IgG3 in multiple myeloma, and the indication in the symptomatic patient, and also the prophylaxis for the rituximab. And the frequency, we give 1 to 3 treatment, and daily or every other day until the symptoms disappear. And the replacement solution, albumin, but if we use it daily, plasma must to be used to replace the deficiency coagulation factor. And the acute liver failure, the rationale is the removal of the inflammatory mediator and the albumin bound and the unbound toxin and the restoration of the homeostatic state. And also the clear indication in the Wilson disease for the removal of the serum copper and the large molecular weight toxin. And the indication when to go to the acute liver failure, as we see the therapeutic plasma exchange, the category 3. But when we use the high volume therapeutic plasma exchange, it is in category 1 with evidence 1A. And the acute liver failure due to fulminant Wilson disease, category 1, also this is the high volume with category 1C. And the frequency, we do it daily until transplant or the clinical improvement. And for the high volume therapeutic plasma exchange, we do the 3 consecutive treatment. And the replacement here is mostly to be plasma more than albumin. And again, the therapeutic plasma exchange high volume target to remove and to replace 8 to 12 liters per exchange. And when to go to the cryoglobulinic vasculitis, which is one of the category 2, the removal is the rationale is the removal of the cryoglobulin to change the antigen antibody ratio and to eliminate the cytotoxin and increase the immunocomplex clearance. This is the indication in the severe and the symptomatic case. And also we can use here the immunoadsorption or the double fractionation membrane plasma exchange, and also the level of 2B here and the 2A. And the frequency is done daily or every other day, mostly for the 3 to 8 procedure or until clinical response. And there's some cases, especially needs the long-term treatment, especially what's called the chronic plasma exchange in the patients with relapsing, frequent relapsing cryoglobulin, and the patients with the recurrent symptoms, and also with cryoglobulinic vasculitis resulting into neuropathy. The replacement fluid here is mostly albumin, but in the immunoadsorption, maybe use the albumin or use the plasma. And the important text here in the cryoglobulinic vasculitis, in the return line and room, must to be warmed to avoid the precipitation of the cryoglobulin, must to increase the temperature of the returning line. The thyroid storm, removal of the T3 and T4 bound to the plasma protein, and the removal of the amiodarone in the case of amiodarone-associated thyrotoxicosis, and the removal of autoantibodies in the Graves' disease, catecholamine and cytokine. This is the rationale. And the indication in the thyroid storm is failing to respond to the first line therapy, because here it is category 2, up within the 24 to 48 hours, or when the first line therapy is contraindicated. And the daily, we do it daily to every other day, every 3 days, we make it daily or every 3 days, guided by the control of the symptoms. And the replacements is albumin or the plasma. And the plasma have the importance and the albumin have the importance because the plasma increase the thyroid binding globulin, and the albumin provides the low affinity binding site for the thyroid hormone. And when to go to the HELP syndrome, and the HELP syndrome is category 3, which is individualized. And the rationale for plasma exchange here is the removal of the circulating protein-bound platelet aggregating and the procoagulant factor that is released from the activated platelet and the endothelial cell. And the most common indication is the postpartum, and it is category 3 to C with the evidence. What is the use? The plasma exchange antepartum, it is 4. 4 mean it is not useful or contraindicated. And the frequency, it is done daily until improvement within 48 to 78 hours after delivery, until the platelet counts more than 100 and the LDH is normalized, and the replacement fluid here is albumin, because we have hemolysis and the elevated liver enzyme and the low platelet count. And the heparin-induced thrombocytopenia also, it is category 3. The rationale is to removal of the antibody against the platelet factor 4, and the indication mainly in the precardiopulmonary bypass or with the evidence of the thrombosis. And we done also daily or every other day until the antibody titer is undetectable, and typically we can use from 1 to 5 procedure, and the replacement is albumin or plasma. In the hypertriglyceridemic pancreatitis, the rationale is the rapid reduction for the triglyceride level, and it is the indication only in the severe cases, and to the prevent the relapse, what is meant by the chronic plasma exchange, and the frequency we done it daily for 1 to 3 days for severe pancreatitis, and the replacement fluid either albumin or the plasma. And the sepsis with multi-organ failure, this is the great dilemma. The rationale is the removal of inflammatory and the antifibrinolytic mediator and the restoration of homeostasis, and the indication in the severe sepsis cases daily up to 14 days or until the symptoms disappear, and the replacement here is the plasma. But there is no clear data to support the clinical benefit of using therapeutic plasma exchange in the setting, outweighing the risk associated with its use. So that the red flag, which is the therapeutic plasma exchange, it is contraindicated in patients with actively septic or who are hemodynamically unstable. When to go to the plasma exchange in the pregnancy? First of all, we can talk about the thrombotic microangiopathy or TMA in pregnancy. Either it is due to the placental cause like the preeclampsia, HELP syndrome, or acute fatty liver. So here the delivery is curative and the therapeutic plasma exchange, it is not indicated. But it is non-placental cause like the thrombotic thrombocytopenic purpura, typical HUS, secondary to the drug or viral infection. Here, delivery is not curative, but the therapeutic plasma exchange is indicated. And they went to go to the obstetric cause due to the autoimmune disease or the red cell alloimmunization. Autoimmune disease like the patients with congenital heart block, multiple sclerosis, SLA, polyneuropathy, or myasthenia, we consider the plasma exchange if there is deterioration of the disease. What is the red cell alloimmunization? When the maternal antibodies is directed against the fetal red cell antigen that leads to the hemolysis of the disease, hemolytic disease of the fetus and the newborn, and the fetal anemia, which leads to death or intrauterine fetal death. So that we consider the plasma indication only in the high-risk case. And this is must be combined with the IVIG in selected high-risk case with a history or sign of severe fetal anemia before the age of the 20 weeks. But the very important thing, when the intravascular intrauterine transfusion, which it is now the new era and the no moderate, is not yet possible. So that in the red cell alloimmunization, it is indicated only in the patient with the signs or history of severe fetal anemia before the age of the 20 week. And when we use, we must to be combined with IVIG, and only used when the intravascular intrauterine transfusion is not yet possible. The important trips and ticks in the pregnancy during exchange hypotension must to be carefully monitored and corrected, and in second or third trimester, it is preferable to place the patients on the left side to avoid the compression of the IVC by the gravid uterus. And also, we must to be close follow-up because premature delivery may occur due to the removal of essential hormone that remain that maintaining the pregnancy. And also there is the era of in the COVID area and in the infections, there is the rule, some rule in the category 3, which is the case and the decision base by base according to the individualization, because the infection in the COVID leads to inflammation and the capillary leak and non-cardiogenic pulmonary edema, and also endothelial activation with capillary leak, intravascular volume depletion and hypotension, and the non-cardiogenic pulmonary edema, ARDS, and the activation of coagulation cascade, and also in addition to the cytokine storm that leads to vasodilatation, hypotension, and the capillary leak, and the non-cardiogenic pulmonary edema, and the pathological coagulation in the form of leads to microcirculatory clot, tissue hypoperfusion, organ failure, and so that the therapeutic plasma exchange used as rescue therapy in the severe COVID case with acute respiratory distress syndrome and the cytokine storm as an efficient and rapid method to remove the inflammatory cytokine, stabilization of endothelial membrane, and the resetting the hypercoagulable state, but it is potential benefit in the patient outcome when it is used earlier in patients with severe disease before the onset of multi-organ system failure. And now we go to the ICU or our experience in the plasma exchange, and this is our disclosure that we present because this is an original work and this is the output of the personal efforts of our team that is conducted in Cairo University Hospital, and we don't receive any specific grants from any funding agency in public, commercial, or not-for-profit sector. This is the start of our journey, which is published in the Therapeutic Apheresis in the 2018, which represent the 6-year experience of the therapeutic plasma exchange. And here, and in this paper, we analyzed the 308 patients treated by 1,783 membrane plasma exchange from 2011 to 2017. And this is our indication that is done for the plasma exchange. And at the top, the thrombotic microangiopathy and the systemic vasculitis with pulmonary renal syndrome, and also the Guillain-Barré syndrome, myasthenia gravis, catastrophic antiphospholipid, antibody-mediated rejection, lupus nephritis with the crescentic GN, and also the post-transplant recurrent FSGS, and also the hyperviscosity with gammopathy, and also the chronic inflammatory demyelinating polyneuropathy. And our experience shows that favorable outcome with thrombotic microangiopathy, systemic vasculitis, myasthenia gravis, and the Guillain-Barré syndrome, and the sepsis was the leading cause of mortality. And to continue this journey, we'd go to what we present, which is the outcome of the therapeutic plasma exchange, a 1-year experience in the internal medicine intensive care unit. And the aim of this study is to continue our evaluation of the outcome of the nephrology care in the internal medicine ICU regarding the bedside membrane therapeutic plasma exchange. And really, in the two work, we use the membrane therapeutic plasma exchange. We analyzed during these years 69 patients treated with 425 membrane plasma exchange sessions in the ICU. And this is the indication. The first one also is the thrombotic microangiopathy with the number of patients 24, systemic vasculitis with pulmonary renal syndrome 14, Guillain-Barré syndrome 13, lupus nephritis with the crescentic GN is 10, and the myasthenia gravis is the 8th, and this is representing the number of sessions that is done for every indication. When to go to the every indication, the thrombotic microangiopathy, which is the first one, the thrombotic microangiopathy was the commonest indication here in the lecture. That include the 24-hour patient. This thrombotic microangiopathy is divided into renal limited TMA with SLE, 6 patients, and TTP or atypical HUS, which is the 18 patient. And this TTP and the HUS is divided into 2 categories. patient with renal involvement, 14 patients, and the patient with neurological involvement, which is the 4 patients. The response was 18/24 with 75%. The rationale in the thrombotic thrombocytopenic purpura is the removal of the ADAMT-S13 autoantibody while replacing the deficient ADAMT-S13 protease activity. The indication in the presence of the thrombotic thrombocytopenic purpura, and we done daily until the platelet count more than 150 and the LDH near the normal for 2 to 3 consecutive days. And we have the rationale for gradual disappearing, not abrupt discontinuation, but the abrupt, it is not wrong. And the replacement here is the plasma to replace the deficient ADAMT-S. And when to use the complement or coagulation mediated or atypical HUS, rationale is the removal of antibody or complement regulator with replacement of exogenous complement factor. And also the removal of the cytokines that damages the endothelium. We done daily until clinical improvement in the complement mediated and the replacement plasma or albumin. DTP and the HUS a sum of 13/18 patients responding to the membrane plasma exchange with response 72%. 3 patients didn't respond, and the 2 patients died. In the subgroup analysis, as we see, there are 14 patients. The serum creatinine improved in 11 patients, 78.7%, and 2 patients didn't respond, and 1 patient died. And for the patient with the neurological deficit, which is 4 cases, 2 patients recovered completely, and 1 patient didn't respond, and 1 patient died. And they also involved the limited TMA, which is the special category for the TMA. And this category involves 6 lupus nephritis patients that is presented with acute rise in the serum creatinine, and the renal biopsy relieved class 4 proliferative lupus nephritis with TMA without. Again, we will go to the subgroup that involves the neurological deficits in these patients with thrombotic thrombocytopenic purpura, which include 4 patients. 2 patients have recovered, and 1 patient didn't respond, and 1 patient died. And the response is 50%. And to go to the special consideration for the renal limited TMA with SLE. This category includes the 6 patients with lupus nephritis that is presented with acute rise of the serum creatinine. And when we do the renal biopsy, it reveals a class 4 and TMA without any peripheral hemolysis or thrombocytopenia. And the only 2 patients of this associated with antiphospholipid antibody syndrome. 5/6 patients, the serum creatinine improved. 3/6 patients, total recovery, and the partial recovery defined by 50% reduction in the creatinine, 2/6 patients. And the improving of the serum creatinine have significantly negative correlation with the serum creatinine before to the therapeutic plasma exchange. And this is the R and this is the B value. And this is systemic vasculitis with the pulmonary renal syndrome and also the lupus crescentic glomerulonephritis. All of us know the ANCA-associated vasculitis. It is category 1 that is considered in the plasma exchange for the removal of the cytotoxic ANCA, either the myeloperoxidase or the proteinase 3. And the first important indication is the diffuse alveolar hemorrhage or the RBGN with creatinine more than 5.7 or on dialysis. And the frequency is done every other day for 7 exchange, but when the diffuse alveolar hemorrhage is present, it is performed daily. And the replacement fluid, it is albumin and the plasma if diffuse alveolar hemorrhage or recent biopsy is done. Common indication. Overall, 14 patients is needed because of ANCA positive systemic vasculitis and the RBGN and the pulmonary involvement. The response rate, 9/14 patients with systemic vasculitis are good. 3/14 patients didn't respond, and the 2 patients passed away. Which are 10 patients. 5 patients and the 3 patients remain on regular hemodialysis, and the patient passed away. And when the patients that need mechanical ventilation, there is the 11 patients from the 2. 9 of the 11 patients were weaned from mechanical ventilation, and the 2 over 11 patients didn't died away, passed away on mechanical ventilation. And the proliferative lupus nephritis with the crescent, this is the 10 lupus nephritis with diffuse proliferative GN class 4 and the crescent, and treated in addition with the pulse steroid. Improvement occur in 8/10, and the 2/10 didn't improve, and they become the chronic kidney disease patient. When to go to the Guillain-Barré syndrome, the indication of progressive disease, inability to walk, or decrease in the respiratory presence of the rationale is mainly removal of antibody against the peripheral myelin, and the frequency it is done 5 to 6 procedure daily or every other day over 10 to 14 days. But here the relapse is common, and they may need the frequent or additional courses of the plasma exchange, and the replacement albumin over the plasma. And there is the 13 patient complete remission occur in 8. The rationale for the Guillain-Barré is the removal of antibody against the myelin sheath, and also we did it 5 to 6 procedure daily or every other day for 10 to 14 days, but the relapse is common and requires additional courses. Our experience, there is the Guillain-Barré 13 cases, complete remission occur in 8, and the partial improvement in the 3, and 1 patient didn't improve, and 1 patient died from respiratory failure. And in the myasthenia gravis, the indication in the myasthenia gravis, either acute short-term or long-term treatment refractory to the immunosuppression, but this is category 1. The acute short-term is category 1, and the pre-thymectomy, it has no clear evidence. In the acute short-term treatment, it is an acute myasthenic crisis and the respiratory insufficiency. In the long-term refractory to the immunosuppression, either failure to respond to the immunosuppression medication or side effect for the medication, mainly the side effect of the cortisone. And the pre-thymectomy, before and after surgery, the rationale is the removal of antibody against the acetylcholine receptor or the muscle-specific kinase or the lipoprotein-related protein autoantibodies. In the acute attack, we do the 3 to 6 treatment over 10 to 14 days. And in the chronic treatment, we do 1 to 2 sessions per week. And the pre-thymectomy, we do 3 to 5 treatment. And the replacement here is albumin. We have 8 cases of response to the plasma exchange. 1 patient didn't respond, and 1 patient died also from respiratory failure. And to go to the evidence of the complication of the plasma exchange, as general, the plasma exchange is an expensive and most costly procedure, which is the cost mainly of the replacement fluid. And it is time consuming, requiring the trained staff and the large bore vascular access. However, the complication rate is not high. The most common causes are paresthesia, and this is mainly occurs due to the hypocalcemia. And the hypocalcemia mainly occurs due to the citrates that is used either the local anticoagulation or the citrates that is present in the plasma, which is binds to the calcium and forming the calcium citrates solubles that leads to the decrease in the ionized calcium, but not the free calcium. So we must to check the calcium total and ionized. And also the hypotension, and this is an urticaria, which is an anaphylactic reaction, may be occur in the first or every session of the plasma exchange. And the alkalosis, this is may occur in the patients with renal impairment due to mainly the failure of metabolism of the citrate, either the anticoagulation or that is present in the plasma into bicarbonate. And the shivering and nausea. We must know that single plasma exchange volume will lower the plasma macromolecule level by 60%, and the 5 exchange during 5 to 10 days will clear 90% of the total immunoglobulin. So the patient is under aggressive immunosuppressive therapy. And there is the 2 specific complications mainly related to the thrombotic microangiopathy and the TTP. First, the patients that receiving the antigen, the ACE inhibitors as an antihypertensive medications before the plasma exchange are susceptible for the hypotension because these drugs, which is the ACE inhibitor, interferes with the bradykinin metabolism. And also, the patient with the TMA or the relapse may have the recurrent thrombocytopenia and the fever several days to weeks before the treatment. But this must to be considered not a relapse. We must to exclude sepsis first, especially the central line sepsis, before considering this as the relapse. So that thrombocytopenia and the fever, in cases of TTP, in the plasma exchange, it is not considered as the relapse unless you exclude the sepsis, especially the central line induced sepsis. And our experience that is met during this 1 year, hypotension occur in 16.2% of the session, and the hypocalcemia occur in 11.5% patient, and the infection, which is the catheter-related infection, occur in 4 over 69 patients, and the 6 over 69 patients that is died, and mainly due to the massive infections, mainly from the MDRD or the Klebsiella MDRD, and also the E. coli and the Acinetobacter. This is the common pathological organism that is occur within the culture from this dead patient. And the sepsis was the important cause of mortality in 6 over 6 of the died patient. And this is, thanks God for this is our accepted e-posters in the next coming era edita. And this is the netcom of all acute nephrology team with the head of team, my dear professor and my dear brother and my dear colleague, Dr. Yasser Abhamid and Dr. Muhammad Mumtaz and the other also associated professors and the lecture. And also this is the assistant lecturer and this is our residents. And also this is after the head of our nephrology team, Professor Salwa Ibrahim. And also we present a plasma exchange in the critically ill patient. This is the critical team or the intensive care units medicine, which is the head Professor Himmat Al-Haddad. And this is my dear colleagues in the units and my dear colleague also to Dr. Yes. And our take-home message, therapeutic plasma exchange is an extracorporeal removal of large molecular weight constitutes of the plasma that are mediators of the disease, antibody cytokines, endotoxin and immunocomplex, lipoprotein, and the highly protein-bound substance in the intravascular space are the common target for the therapeutic plasma exchange. And in the critically ill patients, they may have an indication for the thrombotic plasma exchange, other extracorporeal therapy like the hemodialysis simultaneously, and the special attention should be done to it on the medication, especially in the critically ill patient. And our experience shows that the favorable outcome saw the thrombotic microangiopathy, systemic vasculitis, myasthenia gravis, and the Guillain-Barré syndrome, and the sepsis again, because it was the leading cause of mortality in our case. And thank you.
Thank you, Professor Ahmed, for this highly illustrative talk. You walked with us in a long journey, starting from plasma exchange techniques and highlighting the technique, especially tips and tricks for this technique in critically ill patients. Also, how to manage and deal with critically ill patients in different situations. Indications, not only the technique, but also the indications in critical ill patients. What's the rationale? Why do we use plasma exchange in every case, and why do we expect from using plasma exchange? We are to know what to remove, because the molecule removed can be measured in most of cases or in some cases, and this molecule is to be followed, and this is the follow-up of our case. Not only the clinical picture, but also what we remove is essential to know. In this case, you went with us in this journey through the indications, rationale behind each one in critical care settings. Finally, in the third part of your talk, you expressed in a very elegant way what you did in your critical care work in ICU, internal medicine ICU, in a very simple way, illustrating the indications, the main indications. And as we can see, the main indication between your 6 years experiences published in Therapeutic Ephemeris Journal and the last continuation of this therapy is not much different. The indications are nearly the same with some changes regarding autoimmune diseases. What was the tip and tricks in each indication, and your rationale behind using these in these cases. Complications of plasma exchange, I got a very important message that extherapeutic plasma exchange is a heavy immunosuppressive modality. It is a heavy immunosuppressive modality, as all mortality was related in your cases due to sepsis mainly. It's a heavy immunosuppressive modality, and if we consider that it is used in conjugation with immunosuppressive therapy, we should take care of our patients mainly from immunosuppression, which is the major cause of mortality. I have some questions, and I can see the chat. Dr. Hisham Fayed, excellent and very comprehensive. Thanks for interesting talk. Dr. Mohammed, excellent, elegant. Yasser Nassar, and Lab Pharmacy's experiences and recommendations. And Yasser Nassar, before I have some questions, Yasser Nassar, Professor Yasser Nassar, Professor of Critical Care Medicine. Do you have a comment or a question to start with you?
Yes, please. I'd like to thank Dr. Ahmed. Very, very comprehensive and elegant talk. And I have a comment and a question for him, please, for your experience in the duration of giving the plasma exchange therapy, because I have 2 patients in my head I can never forget. Another thing is that who takes the decision? Actually, I think we should increase the awareness of this very curative modality of treatment, because when we're in the ICU, actually the patients who recover and they get well, they're getting well, and they say bye-bye after they leave the ICU, they are very rare. We love to see patients get well. Patients with TTP, patients with the Guillain-Barré syndrome, myasthenia gravis, these are young patients. These are very hopeful patients. Unfortunately, the diagnosis and the intervention, it gets in the dilemma, like the comment here, who takes the decision exactly? Like if we have a patient, should I wait for nephrologist to diagnose that and then I call the nephrologist to do the plasma exchange, or the other way around? Do I have to wait for the neurologist to diagnose that? It takes a lot of time. So I think the awareness to diagnose, I will share with you a case that I can never forget. It was around in 2013. way back in our hospital. I remember this case. He was around 30 years old, 35-year-old male. He had nothing, no history at all. And he was from Port Said, I remember. And then he came with acute disturbance in the consciousness level and admitted to the ICU. And it was on my way to go home. And he was just beside the curtains. And I say, this is a new admission. Let's go and see. The value of full labs that come immediately with the patients, the full labs taken in the ER. Of course, he did a CT scan, he did the full labs. So I saw the immediate labs that came out with him, and I saw the thrombocytes are, the platelets are very low, the creatinine is high, with the disturbed conscious level, and he was nothing in his CT scan, no acute onset. So I said to the resident, why not think of TTP? Please do me the hemolysis profile and the fractionated RBCs, schistocytes, and so. It took us some time, and he was surprised. And if we didn't do that, if we didn't see that immediately, we wouldn't have diagnosed this case. Alhamdulillah, the other day, we found out that it's true, it was a TTP, and we started plasma exchange. I can never forget this case because the duration, that's my question, the second question. This case, he had a Glasgow Coma scale nearly of 7-8 without improvement. We continued for around 21 sessions of plasma exchange with no improvement still. And we consulted, we continued again and again. We reached a record of around 30 sessions. And I remember very well, his mother, she sold his house, she sold his flat, and I honestly told her, save this money for his kids. I want to tell you, this patient, after the session of the 21 sessions, 22 sessions, he was fully conscious. He rapidly improved later on, extubated from mechanical ventilation. All the complications disappeared, and he went home, shook hands with me, and went home. طبعا we learn a lot of things from our experience, but this case I can never forget because it was a very long daily sessions of plasmapheresis. I think the regular, we shouldn't have exceeded the 18th session, but we continued for 30 sessions to see the great improvement. It's a lesson for me. I hope to know from your experience, how many sessions do you wait to have a clinical improvement? That's in TTP. We have miracles, of course, in Guillain-Barré. The last one was our colleague from after COVID, after taking the vaccine, and she had acute weakness in the lower limbs, and we did the plasma exchange, and she recovered immediately, or very rapidly, and it's curative. So I'm a very great fan of the plasma exchange. I recommend the early diagnosis and the awareness to increase among the ICU physicians, and the collaboration between the disciplines to identify the patients at immediate recommendation, and to be candidates for early plasma exchange, like the TTP, like the Guillain-Barré, like the myasthenia, of course, and the early diagnosis. And thank you.
Thank you, Professor Yasser, for sharing us your experience. And really, I'm astonished with this case. And let me ask you a question. During your 21 or 22 sessions of plasma exchange, did you find any starting improvement that made you to continue up to this huge number, or was no improvement at all, and this was your clinical sense?
As I recall,
that
it was
patient...
10 years ago, but actually it cannot be said as an improvement. And we had all the consultants in the world, but we had nothing else to do but to continue. And it was against all our expectations. We all said, stop it.
Yes.
But actually it happened, and we saw marvelous improvement, but after the 21st session, as I recall.
This is the cause behind my question, that anyone will stop. A comatose patient, now no signs of improvement, and we passed a big number of sessions. At least we expect usually in TTP the improvement to start about the fourth to fifth session. Signs of improvement start, not full improvement, but this what makes us to continue and to see up to the end. But in spite of absence of any signs of improvement, this is a great success, and I want to shake your hands. Me also. I want to shake your hands also. I have many questions regarding the question of Dr. Khalid Abu Zaid about who takes the decision: neurology, nephrology, hematology, oncology, intensivist. I think the one who is in charge. Critical care nephrology is a multidisciplinary work. No one can work by himself. And I can, me and Professor Yasser, we did multidisciplinary work in the era of COVID regarding the care of patients in French hospital during the area of COVID. No one, it doesn't matter who takes the decision. The one who sees the patient takes the decision and consults the other consultants for the care of the patient finally. The second wave was Akram Abdelbari, and regarding the use of ECMO, in addition to CRRT, also was a multidisciplinary work, use of multiple circuits in the same patient, and we passed with some patients regarding an improvement in this multidisciplinary work. Of course, internal medicine specialties, including nephrology, including hematology, we are all working together in this intensive care settings. And I think you all agree with me. The one who takes the decision is the one who highlights, not to say take the decision by its means, but highlights the decision for other consultants to share the decision. He highlights, I need plasma exchange, hematology, nephrology, intensivist, whatever, and the decision finally is shared by all the multidisciplinary team. This is what we usually do, and it is not a one-man show. It is multidisciplinary work. Hope this to satisfy you, Dr. Khalid, and Dr. Hisham Fayed. Please unmute yourself, Dr. Hisham. Professor Hisham. Yes.
Thank you very much, Dr. Ahmed. Very comprehensive. I really enjoyed the talk, and I wish that it's printed out for postgraduate educational mission. Always, Asra Aini is a leader in extracorporeal therapy as well in other of the nephrology aspects. But I can see here the results, and I can see here you are expert in the plasma exchange procedures and plasmapheresis. I just have two comments and a question. It's not a question, it's a wondering one. My comment here is that you said that you prime the filter with 2 liters of saline. The porosity is in micrometer. Again, is that the nanometer of the hollow fibers regularly, even in hemodialysis or hemodiafiltration, superflux. So if you do a 2 liters priming, you have to close the handing because saline will escape rapidly. The cutoff point for the plasmapheresis is around 2 million molecular weight. However, for the high flux, it's only about 30 molecular weight. So it's usually we need to close the handing wall for the priming because saline easily escape. Second one, when you do an anticoagulation, I think in the arterial limb it will not be of value because it will escape. The heparin is around 30, 35 high molecular weight heparin, not low molecular weight heparin. So it's usually injected in the venous limb, which means that the patient anticoagulation. So you cannot prime with heparin because heparin easily escape from that. For the NABDAR, yes, I wonder that it's 20s, but we see before patients requiring 20s. I remember last one was post-vaccine, COVID vaccine, thrombocytopenic immunology of the vaccine. And we did a lot of around 23 with no response. Then we gave the monoclonal antibodies and repeating the renal biopsy. And it showed that even with the monoclonal antibodies, the patient is still dialysis dependent. My question is, you use that plasmapheresis in systemic lupus. I'm wondering that because systemic lupus usually is not indicated to do plasmapheresis except if it's associated with TTP or severe cerebritis. You mentioned that if you have an improvement, but you give as well IV solomidrol pulse steroid. So what's the rationale to do thrombotic microangiopathy, for example, in lupus or other indication, just to highlight your rationale for plasma exchange in lupus patients?
Dr. Hisham, thanks for your question. We use the plasma exchange in the two indication for the lupus nephritis. The first indication, which is the lupus nephritis, which is the thrombotic micro with the thrombotic microangiopathy without evidence of the peripheral hemolysis. Okay, so in this category, we use the plasma exchange.
Yes,
and the other issue that we use is the critically ill patient with lupus nephritis that is received an immunosuppressive medications plus the mycophenolate mofetil and also the steroids and also the hydroquine, but it is not improving. And that is presenting to us with acute rising in the serum creatinine and rapidly progressive glomerulonephritis. And the biopsy is revealing rapidly progressive lupus nephritis with the cellular crescent and the fibrocellular crescent. So we use it as the rescue therapy. It is not an indication, as you say, Professor Hisham, with the first indication is to give her the cyclophosphamide.
We usually give cyclophosphamide or even rituximab later on.
Yes. This is what, but these patients are the resisting patient, and this is presenting to us with the acute deterioration of condition over the last 3 to 6 months. And these 6 patients, I remember it especially because they have the cellular and the fibrocellular crescent. And the number.
So just for the audience, that plasma exchange is not indicated routinely in patients with lupus.
No, it is. It is not.
The most indication is with the TTP and
with the renal limited TMA and also with the lupus cerebritis, also that is resistant to the treatment. But in the crescentic, it is in the low back of the row.
Usually, if you have a male patient with systemic lupus, it probably will be very resistant to immunosuppression. Thank you again, and really I enjoyed that very much.
Thanks, Professor Hisham. Thanks.
Thank you, Professor Hisham. I have a question, Professor Ahmed, regarding what do you have a specific recommendation regarding inotropic use while using plasma exchange? Adjustment to the dose, adjustment of timing, adjustment of something.
No, Dr. Yasser, but simply, we can't initiate, as I say, the plasma exchange unless the patient is hemodynamically stable. Hemodynamically stable with the minimal doses of inotropes that will occur, because the plasma exchange, as we see, they reduce the inotropic dose into the subtherapeutic levels. Okay, so that there is no adjustment for the dose, but we restrict the plasma exchange to the hemodynamically stable patient. If the patient is hemodynamically stable, we must do hemodynamically stable at first. And as the rationale, as Dr. Yasser, his elegant cases that is received the 21, and our rationale is to give the 3 sessions of the plasma exchange and then to assess the presence of infection or not by the sepsis. If not, we continue. If the presence of sepsis, we stop. So that the hemodynamical stability in the patients with ICU is a very, very important thing. And the minimal doses of inotropes, we start it because already the plasma exchange reduce it to the subtherapeutic level.
Thank you for this tip in using plasma exchange. It is not like CRRT, which is used mainly in hemodynamic unstable patient. It is hemodynamic stability is maybe a major obstacle to use plasma exchange. And this may be the cause behind the lack of good results in septic patients. That most septic patients are hemodynamically unstable. Regarding the question of Dr. Khalid Abu Zaid, lipophoresis experience and recommendations. I have a case in my past experience, and I think Professor Ahmed will share with me another experience recently. My case in the past experience was the use of lipophoresis and plasma exchange in patients with hypercholesterolemia. This patient was depending mostly and receiving all plasma, all anti-hypercholesterolemic drugs, and nothing was successful except of plasma exchange. Unfortunately, this patient was subjected to plasma exchange repeatedly I think was every other day or every 2 days, what resembles dialysis. And she stayed like this for a long time to protect her against cardiovascular complications, which were started to be prominent in her young age because of her hypercholesteremia. But the only way for her plasma exchange, her disease, is to do plasma exchange frequently in a similar way to the dialysis every other day or every 2 days. Regarding the patient of hypertriglyceridemia, Professor Ahmed, we shared one, I think, a few weeks ago.
Yes. And I said, Dr. Yasser, in the experience also and in the literature, we use the plasma exchange in the hypertriglyceridemia with pancreatitis. These patients with acute pancreatitis, it is indicated when the triglyceride is more than 1,000 milligram per deciliter after initial resuscitation with the insulin infusion, and this is resistance. And we have the patient with the recurrent acute pancreatitis and admitted to our ICU within 1 month, and receive the IV insulins, and also this not leads to the improvement, and he started to develop organ failures in the form of elevated kidney function and elevated liver function. So we initiating the plasma exchange 3 sessions, and we discharging the patients on the chronic plasma exchange 2 sessions per week.
Okay, thank you. Professor Yasser, I think regarding hyperlipidemia, did you meet cases with severe hyperlipidemia needed plasma exchange in your clinical practice? Do you remember them? I think they are major landmarks. Did you meet some of them?
Actually, not in acute phases, not in my experience, actually, but of course, I have met cases that were very young age and they underwent, we did coronary angiography and we did CABG for them, open heart surgery.
Yes.
But plasma pheresis or plasma exchange, not in my experience, but of course, they are referred to your centers, but not in acute situation. No, I haven't seen them in the ICU. No.
Okay. Thank you. Question from our moderator, Dr. Mu'tasim Fayed. What is the proper, he's speaking about transplantation because he is from Kidney and Neurology Center in Mansoura, the major center in transplantation in Egypt. What is the proper sequence on combining IVIG therapy with plasma exchange? Can we give IVIG immediately after each plasma exchange session every other day, or give it once at the end of the last plasma exchange session? Means to do interrupted with IVIG after each one, or to finish all your treatment plasma exchange followed by IVIG?
As I say, Dr. Yasser, regarding the first, the rituximab and the IVIG, which is used in the antibody-mediated rejection. The rituximab is given when we start the plasma exchange 24 hours after the plasma exchange. We give the plasma exchange 24 hours after administration of the rituximab. In the IVIG, we give the plasma exchange after the IVIG by 36 hours.
So it is related to the clinical condition,
related to the clinical condition.
Frequency of need of how many sessions, how many doses.
Yes, according to the patient. But when we combine the IVIG, rituximab, and also the plasma exchange, we give the plasma exchange 24 hours after administration of the rituximab, and we start by the IVIG, and also so the plasma exchange will be given at day 36 to the 78 hours after the IVIG.
Let me ask you a question about your experience regarding the patient with bleeding tendency.
Yes.
Plasma exchange is a concentrating method that makes the extracorporeal circuit increase the extracorporeal circuit concentration, increasing incidence of coagulation. What do you recommend in case of a bleeding patient or patient with bleeding tendency to use?
Yes, the use of the replacement fluid, as I said, the replacement fluid we divided the replacement fluid into 65% colloid, which either the fresh frozen plasma or albumin, and 35% which is a saline. And this division reduces the cost of the plasma exchange. If we do the plasma exchange in the patients with the recent hemorrhage or bleeding tendency, whatever the cause, we mostly use the fresh frozen plasma, mainly more than the albumin, to correct this coagulation deficit, whatever it is, the alveolar hemorrhage or the bleeding tendency that is the present. And also when we consume the plasma exchange daily, we recommend to use 1/3 of the dose by the plasma to correct the deficiency coagulation factor.
What about the use of extracorporeal anticoagulation? Do you, in this case, bleeding cases?
Extracorporeal anticoagulation, the use of the extracorporeal anticoagulation according to the platelet setting. According to the platelet setting. But the plasma exchange, it needs the high doses of the plasma of anticoagulation that I said. We don't use the citrate as the regional anticoagulation because we are dealing with the membrane plasma exchange. If the platelet counts, it is to be low with the bleeding tendency, we will change the anticoagulation into the fondaparinux that we use in the hemodialysis to reduce the bleeding tendency and reduce the platelet count.
Professor Hisham wants to comment?
Yes, I probably missed the sepsis and plasma exchange. Please remember that bardo plasma exchange is not indicated in patients with septicemia. And please remember that you are removing both the pro and the anti-inflammatory cytokines. So the decision to do plasmapheresis in septicemic patients is still questionable.
Yes.
The additional factor, that CRRT or prolonged intermittent renal replacement therapy is much more enough to remove cytokines rather than the plasma exchange. As well in the COVID, I memorized that I was a reviewer to a paper in blood purification on the indication of plasma exchange in patients with COVID. And I rejected this paper unfortunately because unless there is thrombotic microangiopathy in renal patient with COVID, there is no indication. So just to highlight that, don't rush to plasma exchange in patients with septicemia.
Yes, of course, totally agree with you. Totally agree with you, Professor Hisham. And Ahmed was, I think, strictly clear, and I will ask him to repeat what he said about this point.
I probably
specific indications, specific indications in sepsis, and usually we do this. And he said about an important point that most patients are hemodynamically unstable with sepsis. Usually, if severe sepsis that in this case are hemodynamically unstable, so plasma exchange became an immunosuppressing in addition to hemodynamically compromising tool with very doubtful results. I think it is not of a choice. Please, Professor Ahmed, can you repeat what you said about to stress again for audiences, as Professor Hisham said, about indications of use of plasma exchange in sepsis?
In sepsis, the plasma exchange, I said, Dr. Hisham, it is a rescue therapy, but all data don't support the use against the risk. And they said the clean word, it is contraindicated in hemodynamically unstable patient with sepsis. And also when it is used in COVID, it must to be used very early before the development of multi-organ system. And I bought a red flag, and I will share again the slide for this. They bought the red flag for its use in hemodynamically unstable patient in multi-organ system failure.
Yes, because you remove the anti-inflammatory cytokines. In COVID as well, in COVID, you are removing the preformed antibodies against COVID. So the risk of plasma exchange, even in patients with COVID, is very high risk because it's a blind technique you cannot remove selectively. So you will remove as well the antibody against COVID.
Yes, Dr. Hisham, and this is the slide that we said. It is active in the active list. It is a red flag warning.
Yes, exactly.
The same for CRRT, Professor Hisham. The lack of success, despite of many studies and many years of study of this issue, specifically in CRRT with no major improvement or no major advance in treatment regarding the use of extracorporeal manipulations or therapy in cases of sepsis.
Sure. Thank you very much.
Thank you for your share. No more questions and no more comments, and we are to close. Professor Yasser, can you close with me first?
Thank you, everybody. Thank you, Dr. Ahmed Fayed. Thank you, Dr. Hashim. Thank you, my dear colleague, Dr. Yasser Abdelhamid, and thank everybody for attending and enjoying with me. I really enjoyed it. Thank you very much for sharing this wonderful sessions, and looking forward for future educative sessions like this. Thank you very much.
Thank you, Professor.
Very, very nice. I really enjoyed it. Thank you.
Thank you, Professor Yasser, for sharing us and for being with us today. We enjoyed your presence. We enjoyed your comments. And I really enjoy our multidisciplinary work with your teams every now and then. And I would like to thank specifically Professor Ahmed Fayed for his clinical work, for his activity, for his continuous enthusiastic work in the ward and in between patients. What was translated in this excellent, highly elegant, comprehensive talk representing his work regarding critical care settings. Thank you, Professor Ahmed, for your highly illustrative talk and for your response, prompt response, and for all questions, discussions, and comments. Excuse me to close this session and announce for the coming session before closure, as usual, will be next Wednesday, inshallah, 9 p.m. Cairo time, will be Professor Mona Roshdi will speak about the dilemma of using proton pump inhibitors and their effects on the kidney, useful or non-useful, how to use, when to use, to what extent, and we are waiting for her lecture next Wednesday, inshallah. تصبحوا على خير. السلام عليكم ورحمة الله وبركاته.